in my classes mention that there are midwives on staff, can they say, I want one of the staff midwives to work with me?
Well, if they have their doctor, they'll be working with their doctor. If they don't have like a midwife that is going to stay with them only. The midwife will be there to assist them and manage them if they need to. But it's not like a midwife is going to be there just for them because they have their doctor. But if they need any kind of intervention, a procedural intervention, then they are there to help them out.
And then the other question I have, and I think it would probably be helpful for a lot of the people in the room. I've been calling, and I know it's been really packed lately. I would love to see a tour for childbirth educators, doulas, so that we can get the most current information about this part. And I've been calling and I've been told, sorry, it's too busy, you can't go on a tour. But I don't really want a regular tour. I need a tour different from what pregnant people go on. Do you think that can be arranged?
I am sure we could talk with the tour people and the midwives or the staff in labor and delivery. I guess that's something that we could do. I don't see that.
That's something that would be very worthwhile. So that
Yeah.
you guys would
That would be wonderful.
Yeah.
So she has a question I wanted to.
Actually, I have a couple of questions. The first one is in regards to the midwives that are working currently at Cedars. If we have clients and stuff that are interested in the midwifery more model of care as opposed to like a more traditional OB, can they get referrals from names of midwives they can contact that have privileges at Cedars by calling the hospital?
There's one midwife right now who has admitting privileges at Cedars, and to my knowledge, that's the current list. Her name is Deborah Frank. Debbie Frank, and she works with Dr. Frank. She's not working. She's the one person who does have admitting privileges, and then they have a physician that she pairs with for sort of a high-risk situation. But our on-staff midwives don't have admitting privileges.
Okay, and then my other question is this. I always go, there's always room for change in every discipline around birth. There's change I'm a doula trainer. There's change that the doulas need to make. They need to go in and not piss the nurses off by acting like they're the authorities and the nurses don't know beans. So I get that there's like room for every one of our disciplines to change. And so my question is this. One of the things that concerns me as a birth professional and doing some birth advocacy is when I look at some of our statistics and I look at those and I see that we're 42nd in the world in infant and maternal mortality. When I look at the fact that Amnesty International just did a huge expose on deadly delivery in the U.S., I think there's room for improvement in our birthing system. We own it. It's our birthing system. There's improvement for when you have women who, after the birth, are having post-traumatic stress disorder because of their birth experience. Some of us have held those women sobbing that can't bond with their babies in our arms. And so my thing, and throwing it out to you, I love that you're a panel here. I would love to get your opinion on what you think as a nursing community, or if you want to bring doulas in, or whoever you want to address it to. What are the changes do you think that we can do on a practical day in and day out level to change some of the outcomes that we're getting?
Well, we at Cedars have made great stride in having the patients bond with their babies right away. Before, we used to send the babies to the nursery. Right now, even on C-section babies, we give the baby to the mother as soon as possible. They may not birth in the OR. If they have surgery, we take them to the PACU. We do not separate the babies unless it's absolutely necessary. And even when we have to separate them, we try to give the baby to the mother, even the preemies. Put it on her cheek, put it on her chest, let her smell the baby before. And then we have the father, bond as much as possible. We take pictures. We really have made great strides in keeping the family unit together.
Actually, it's funny that sometimes the parents ask us to take the baby away.
Yeah.
And we're like, what? You don't want to keep the baby? And it's turned around the complete opposite. Now, the nurses are annoyed at when the patients have the babies in the nursery. But that's your baby? Yeah. So, and your baby wasn't here last night, and you can't breastfeed? Yeah. So we actually are the opposite now. We've gone full circle. We're annoyed when our patients don't want to keep their babies. And even if it's their second, third, or fifth, yes, Diana.
It's a rather somber topic, but unfortunately it's something that I deal with more than I'd like to in my own practice, and that is infant loss. And I'm just wondering, so that I can be more helpful in understanding the background before someone gets to me, what happens at the hospital when there is an infant loss or when there's a stillbirth, or is there some kind of a process that goes on after?
I want to add to your question, just because Monica and I have had separate conversations about this. When this happens, I'd like to also know, when you answer this, how it affects you as a nurse on your rotation, in your day-to-day, when you experience a trauma like this. Because you're experiencing the residual effect. So.
We've all done it,
What happens after? at the
Well,
hospital?
when they come and they have a loss, we try to, support them as much as possible. It's a difficult time. Usually they are doing the labor, they're like, in denial, in shock. So you just have to labor them with as much compassion as possible. There are nurses that do this better than others. And it seems like on any given day when this happens, there is one of those nurses that can take care of that patient. We are very good at following up on our patients while they're in the hospital, after, even when they're postpartum, and the whole process after delivery, we take pictures, we have the baby box that prints all those, memories. Sometimes the patients don't want it, but we still take it because, they may say no today and yes tomorrow, so they can always access that. And there's social service that come and see them. And I'm sure they're given information on follow-up care, where to call, where to groups to get affiliated with after they leave for their support. We've tried to develop a bereavement team that include nurses that make a phone follow-up a few weeks after. That's not, totally established, but the information and the social services is given to them so that they have that.
We also give them an option too. Some of the moms want to be on the mother-baby unit where they can hear the other babies, and some don't want to be. And so we ask them, would you like to be on the other unit where you don't have to hear babies crying? Some of them are torn, so we do try really hard to. Yes.
This may be an unrealistic proposal, but sort of responding to what Dinah said, maybe one of the things is that would help move things along is to have some of the OBs here at a meeting like this. That's where a lot of the power is, and particularly maybe even some of the male OBs. It might be interesting for them to be part of this discussion, because that's in some ways where the change may need to happen. I'd love your comments on that, and how doula-friendly, how open you think the OB staff is at Cedars, because I know there are changes in each hospital.
Well, I think our doctors are fairly open-minded. We have a very young population now. A lot of the older doctors are
don't like computers. We have doctors that are connected, and any of the doulas here come to Cedars. I think I've seen you guys. Yeah, I think that's what
You definitely want to do
Love this.
Yeah.
There's also
And I think some of the doctors, there are few practices like cats. You know, they have like, they're connected to a doula and trained, and they have those doulas and they come all the time and they refer their patients to doulas because they have the population, they want their patients to have a doula. And if the patient is agreeable to that, the doctors are agreeable to that. I don't think the doctors have any problem with doulas.
I think the doctors value the patients having support, but the reality is they're just there less. And so there's less sort of overlap in time presence, that the OBs and the doulas are there at the same time. It's more, I think, the doulas and the nurses.
How do you process loss?
Right. How do you
Well, as Kathy asked.
I know I recently had one, and it was one that, you know, the mom did not want to see the little baby, and the baby didn't die right away. So there was no one left it was a Sunday, and there was nobody left to stay with the baby except me. And, you know, so and there was nowhere to go, so I was just in the OR with this. I don't even remember how many weeks he was young. And the way I process, I just let myself cry. I let myself really be sad and just really, I think I talked with Kathy afterwards too, but it's like, I think the more human we can be, and even with the moms when they're going through something like this, to like let the walls down and just, you know how they say like have some distance and stuff, but I don't feel like I do. I just feel like not many boundaries. Boundaries, but, just to really feel it. And then you kind of go home and maybe you cry a little more, and then it kind of goes away. It just kind of goes
But
away.
I think when you're real, you give the patient permission to be real.
Yeah. Right, without trying to take away from what they're going through, Not about me.
Just let them know that we're there for them, and we're going through this with them.
And it's just it's not a good situation. Like, nothing we can say.
And if after the nurses, really are in a place where they need support and need to talk to somebody, we have the psych nurse that we could call and
Grief team. Yeah, there is.
the grief team, and that we can go over it, talk about it, and come to some resolution.
Yes, I know you were first, and then we'll take both those questions.
I just wanted to go back to what Diana was asking. It's not your fault. You have protocol that is so strict, especially in terms of constant fetal monitoring, which as a doula is a little bit concerning to me, just because we haven't had any long-term studies on the effect of constant hour after hour after hour fetal monitoring going into a fetus and what that might do to a child. And I know there's tremendous pressure for you, particularly with the Dennis Quaid twins, and I mean you guys have incredible pressures on you that I have ultimate respect for. I guess my question is, how do you separate the low-risk moms from the high-risk moms? I mean, do you foresee a day where maybe midwives will be delivering the low-risk moms, and OBs will be, because they're specialists and are trained for pathology, will be more oriented towards the high-risk moms? Because I know you have a lot of high-risk moms at Cedars, but down the road, do you see there might be an opportunity for moms that truly want to come in without a lot of intervention, for there to be a lot of support for that? Because it seems like there isn't right now, and it's not your fault.
Right.
That's our hope. Well, we wish the ladies could, get up and we monitor them every 15
You
minutes.
guys are great. I've had nurses that have been on the floor, holding the monitor. I mean, you guys are awesome.
Yeah, we wish we could do that, but this is California, this is the law, and this is...
It's the clientele.
This is the clientele. The ladies are older, and they have, they have lots of stuff. And it's a doctor's order, that's what happens when you come to the